Hi, this is Dr. Joannides, Chief Medical Director at Optimum and this is the Optimum Academy, Pulmonary 101, video number 9 on obstructive sleep apnea. So let's get started. So what is obstructive sleep apnea? Normally when you sleep, there's an inflow and outflow of air through your nose and mouth into your lungs. However, in some people, the flow is blocked, kind of like the back of the tongue or other structures can block the flow of air, and people have difficulty breathing at night. So they have fitful sleep, they wake up with gasping, they snore, and it leads to a lot of problems which can actually be serious if the situation is not diagnosed and treated correctly. So typically what's done is somebody snores or has symptoms that suggest maybe sleep apnea is present. A sleep study or polysomnogram, abbreviated PSG, is done. So they go into a lab for an overnight sleep study, or it can be done in the home. It just doesn't, it may not be as technically sound as when done in a lab, a sleep lab, which is more reliable, but it can offer some help in diagnosing sleep apnea. So the patient would be attached to many leads, including an EEG for brain waves, lead to check eye movements, muscle movements, an EKG, oral airflow measure, thoracic and abdominal belts to see if the chest is moving, oxygen saturation, microphones may be used to record sounds, and there may be video recording. So it may be split into two parts. So the first part is the patient goes to sleep without any CPAP device present, may exhibit symptoms or signs of sleep apnea, and then a CPAP device may be attached to see if that can reduce the number of apnea episodes that are recurring. So you can see all the connections and wires here that may be necessary in order to do a sleep study. So what are the indicators we use to diagnose sleep apnea? One is called the Apnea Hypopnea Index, abbreviated AHI, and also there is the Respiratory Disturbance Index, abbreviated RDI. Now some people use these synonymously, but there is a slight difference with AHI. An apnea is complete cessation of airflow, so there's absolutely no airflow passing. A hypopnea, the H, is a partial cessation of airflow, and then the AHI is the number of apneas plus hypopneas per hour of sleep. So if you see that abbreviation, AHI, that's the apneas and hypopneas per hour of sleep. The RDI includes the number of apneas, hypopneas, and respiratory arousals per hour of sleep. But as I said, they're used often interchangeably despite the slight difference in their definitions. So how does the American Academy of Sleep Medicine structure the risk groups in sleep apnea? So mild obstructive sleep apnea is 5 to less than 15 AHI or RDI per hour. Moderate is 15 to 30, and severe sleep apnea is 30 plus. So what are contributing factors to obstructive sleep apnea? Overweight build may often be present. People that drink alcohol, especially late at night before they go to sleep, or they use opioid pain medication or sedatives at night, or if they have oral sinus or jaw problems, that may contribute to obstructive sleep apnea. So there's different subtypes. which some people use to help describe different types of people that have sleep apnea, and I've listed them here for completeness. But for our purposes today, I just wanted you to be aware of them, and you can refer back to this at your leisure. So what are treatment options in obstructive sleep apnea? Treatment options can include continuous positive airway pressure, so you're hooked up to a machine that pushes out air, and you use a mask to attach that over your nose and mouth. And there's also a machine called BiPAP, which is a separate inhalation and exhalation airway pressure setting. So CPAP is continuously blowing positive air, whereas BiPAP has different settings for inhalation and exhalation. Some people may use an upper airway stimulation device. You've probably seen those advertised on TV called Inspire. And that actually stimulates the back of the tongue to assist in moving it forward so air can pass freely in and out of your lungs while you're sleeping. There's oral devices or appliances that can be used. Some people have, this is a long word, uvulopalatal-pharyngoplasty, also abbreviated UPPP surgery, to help surgically correct defects that may be causing obstructive sleep apnea. So the good thing about these newer CPAP devices is they actually send digital reports on the usage compliance to the prescribing physician. So sometimes when you review the attending physician statement, you'll be able to see how often and what the duration each night is of the use of a CPAP machine, which gives you some idea of the compliance of the patient with the device, which can be life-saving if the person has really severe sleep apnea. So here's this continuous positive airway pressure machine. You can see it depicted here. So it delivers a constant stream of air through a tubing to the mask. This prevents the airway from collapsing during sleep. It reduces snoring and allows more restful, restorative sleep. And newer units provide data streams that monitor compliance and duration of hours used each night. They used to be very noisy, but they're getting to be less noisy, so less bothersome to a spouse or partner who may be trying to sleep in the same room. And one of the things that's always necessary is to keep the tubing clean, and there may be machines that provide ways to keep the tubing clean, which is always a problem that you want to address. Now, we talked about this UPPP surgery. So an ear, nose, and throat doctor would remodel the uvula, pharynx, and palate for better breathing. Hopefully they order a sleep study after they do the surgery to see if it actually corrects someone who may have sleep apnea. So when you see this, you have to use your own judgment whether the surgery has actually been effective in taking care of the sleep apnea problem. This is that device I mentioned before about using Inspire for obstructive sleep apnea. So it moves the tongue forward by stimulating it. So before you go to sleep, after it's installed, it takes about 30 days of a waiting period, and then it can be used, and you have a separate device that you turn the device on, and the stimulator sends a gentle pulse to the nerve that controls your tongue's motor function. So the tongue moves forward, clearing space for the air to pass. So hopefully the pulse that is sent is strong enough to move the tongue, but not strong enough that it's waking you up and bothering you at night. When you are ready to go to sleep, there's a 30-minute delay, so it allows you to go to sleep before the device starts working. And here's how it would be implanted in the chest. The stimulation lead goes to the back of the tongue. There's a respiratory sensing lead that tells the device, when to fire. So it stimulates cranial nerve 12, or the hypoglossal nerve. So this is the Inspire device that you may have seen advertised. And this is a New England Journal of Medicine article on Inspire. It was funded by the company that sells the product, but it shows that in this group of people, it helped with obstructive sleep apnea in this particular group. There's eligibility requirements. You have to have tried CPAP before, and the way it was tested originally, it was on people with a BMI under 32. Obviously now people with BMIs over 32 are still getting the Inspire device implanted. So the eligibility may have been modified somewhat over time. When would you not want to use this? If there's a lot of episodes of central sleep apnea. In other words, the sleep apneas are not due to that obstruction that we talked about, but it's actually from the respiratory center in the brain is causing you not to take breaths at night while you sleep. So this would not work. Stimulating the back of the tongue would not help with central apneas. So as you can see, there's a variety of contraindications of people who cannot use this Inspire device. And here's the handheld remote that you would use to turn the device on prior to sleeping. So approximately 30 days after getting the Inspire implanted, you turn it on, and then you can actually step up levels of the impulse to the back of your tongue, so you can get the ideal settings so that you have the movement of your tongue forward to give you the best breathing possible during the night. So here's central sleep apnea that I mentioned. It's not due to a blockage in the oropharynx, but it's the brain's respiratory center in the medulla and pons does not generate an impulse to initiate a breath. It can occur with neurologic diseases like after a stroke or something like that. Now, when you read a sleep apnea study, sometimes you'll notice some incidental central apneas. And it may be just because the way the leads are connected, leads can sometimes fall off, and it appears that somebody had a central apnea when in fact they didn't. It was just due to a recording issue. So sometimes you have to take reported central apneas with a grain of salt, especially in home sleep studies where the leads may be not as well applied or whatever as they would in a sleep lab. So what are the underwriting factors in obstructive sleep apnea? You want to know the severity of the symptoms and what the AHI or RDI is per hour, the level and duration of oxygen desaturation below 89%, what the compliance is if CPAP has been prescribed, whether the person has gained or lost weight. And one thing I might mention here is since the build contributes significantly to sleep apnea in many cases, the new GLP-1 drugs like Ozempic and Wegovy are helping people lose significant amounts of weight, and that weight loss can actually improve someone's symptoms that has sleep apnea. So actually these new GLP-1 drugs may be contributing to a much more favorable outcome in people with obstructive sleep apnea, especially if build is involved. You want to limit contributing factors like alcohol or drugs, especially late at night before sleep. And if you notice that somebody has high blood pressure that's difficult to control, and they have a diagnosis of sleep apnea and they're supposedly using CPAP, that may be a proxy. If the blood pressure is not coming under control, that the sleep apnea is not being treated effectively with whatever means are being used for that particular patient or applicant. So if you see elevated blood pressures in people with sleep apnea, that may mean the sleep apnea is more severe or not being effectively treated. Now that completes our last video in the Pulmonary 101 series.